Well, today's the lecture is on joint pain. Joint pain. There's a patient who presents to us with joint pain. So, how do we approach? So, first, we take the ID and demographic data as for any patient. Then we say when were you completely all right and then what happened, and we chronologically record the symptoms. Then about each symptom. The symptoms of joint can be pain, swelling, deformity, loss of movement, of one or many joints. Now, this can be with involvement of the vertebral column. And sacroiliac joints. So, pain, swelling, deformity, loss of function. And out for each of these chronological symptoms, we have to ask onset, course, duration, treatment taken, response, aggravating factors, relieving factors, and associated factors. About pain specifically, we have to ask 4 more questions: site, character, intensity, and radiation. Then we do a thorough general and systemic examination. After taking a past history, personal history, socioeconomic history, especially the effect of the problem on the activities of daily living, vocation, and socio-recreational activities. So after this, we do a thorough general and systemic examination to detect any cause of pain, any cause, but specifically a thorough general and systemic examination is done. Then specifically, we always tend to see the mouth opening, cervical spine movements, cervical spine movements, mouth opening, cervical spine movements, and chest expansion. so that we can assess whether there will be any problem with anesthesia in this patient. Fitness for anesthesia. Then, after an unbiased general and systemic examination, we do a local examination. Which joints are involved? What is involved in those joints? The ligaments get infected, get involved in an immune reaction, and there is calcification of these ligaments. The condition is called as enthesmopathy. So the ligaments can be involved, the synovium can be involved, leading to synovial effusion. In many joints, the involvement is, for example, in rheumatoid arthritis. Single joint involvements may be infective, like septic or tubercular. And they can also be as a result of metabolic disorder, which means gout or pseudogout. Then there can be a synovial effusion, synovial thickening in a condition which is called as villonodular synovitis. These are the various conditions of synovium that can cause pain. And the third type of involvement is articular cartilage. Articular cartilage can be involved in infection, which can be TB or septic. In TB, the first, supposing these are the two articular cartilages that are articulating. So first there can be a kissing ulcer, an ulcer here and an ulcer here. So these kissing ulcers would produce pain in the range of movement. So these are called as kissing ulcers, and they would produce pain in a range of movement, and this movement can be prevented by spasm of muscles, which can lead to deformity. The more powerful muscle will pull the joint in that position. So this is the first stage. Then the second stage is that between these two there is fibrous connection. There is fibrous connection. This is called as fibrous ankylosis. It is seen in TB, and TB is usually monoarticular. These infections are usually monoarticular, single joint involvement, and usually in large joints. So that fibrous ankylosis is classified by no movement and attempt to move is painful. Then the third level is bony ankylosis. Bony ankylosis. So this is called as bony ankylosis, and here there is no movement, no pain. So these are the involvement of the articular cartilage because of infections. Then there can be involvement of cartilage by immune reactions, which is post involvement of ligament in seronegative arthritis, spondarthritis, or ankylosing spondylitis, or synovium, as in case of rheumatoid arthritis. But these are basically polyarticular. The rheumatoid arthritis is small joint, symmetrical, synovial, involvement of the upper extremity hand in a fat fertile female of fat fertile fair female of 40. The ankylosing spondylitis is a young male with pain, spine involvement, spine and sacroiliac joint involvement, decreased chest expansion, and lower limb asymmetrical involvement of large joints like knee. And this is associated with other tissues that can be involved, and they are the iris, uveitis, urethritis, arthritis, which we call the Reiter syndrome, the lacrimal and the salivary glands, which we call as Sjogren syndrome, intestine, which we call as enteropathic arthritis, skin, which we call it psoriatic arthritis. So this is the presentation of ankylosing spondylitis type of immune involvement. So this can be a rheumatoid arthritis type, which is primarily ligamentous, and it can be a rheumatoid arthritis type, which is primarily synovial. Then there can be involvement of, there can be pleural nodules, and that is called as Kaplan syndrome. Then there are many immune arthritis where the systemic involvement is predominant, and they are characterized by that they are called as lupus erythematosus, systemic lupus erythematosus type of diseases, which consists of polyarthritis nodosa, and giant cell arthritis. So systemic lupus erythematosus, polyarthritis nodosa, and giant cell arthritis are those where the systemic involvement is predominant. So we have been able to classify joint involvement, and the joint involvement can be first which joints, large or small, whether ligament is involved, there is tenderness and calcification, whether the synovium is involved, whether the articular cartilage is involved, and these are the components of the joints. And the effect of joint involvement is usually on muscles, which may become spastic, which undergo spasm and produce deformity. Now basically let me tell you what is happening in most of these problems. Most of the problems are related to immunity or degeneration. So first of all, the immune articular disease. So there is an antigen. This antigen is basically called as peptidoglycans. So if a person with a particular HLA type, human lymphocyte antigen, which decides which cells are self, which proteins are self, and which proteins are foreign. So certain HLA types like DW4, like HLA B27, like A28. Now these individuals against these antigens develop antibodies. And these antibodies then combine with these antigens and form what is called as immune complexes. So infection by peptidoglycans positive organisms like Yersinia, like Shigella, like other peptidoglycans positive organisms with these antigens in particular type of individuals. Now this combination will cause the problem. Now these complexes would deposit at various places. They can deposit in where ligaments are attached to bone. This is a bone and here is the ligament. So they can go and affect here. This type of pathology is called as enthesmopathy. Then they can go and attach to synovium, which will be called synovitis, and its mother type of involvement is rheumatoid arthritis. And this type of involvement, where there is inflammation, there will be inflammation, there will be ossification of ligaments, and because of the muscles there will be muscle spasm, deformity. So this is the pathology of enthesmopathy. Synovium is involved in rheumatoid arthritis, but there is a third type of involvement also which we must look for every time, and that is soft tissue. So eye, oral cavity, mucosa, salivary glands, heart, pericardium or pleura, kidney, intestine, large intestine, which is called as ulcerative colitis, then urethra and bladder, or skin, psoriatic arthritis. So these are the soft tissues that can get involved with this type of inflammation. So when these antibodies are being produced by the B cells, B lymphocytes, so there is so much of immunoglobulin, you know that this is the FAB and this is the FCPs. There are so many immunoglobulins that they can produce a very dangerous substance which is called as amyloid, and this can deposit in various tissues, especially the kidneys, causing renal failure. But that's a rare complication of immune articular diseases. So this is the basis of immune articular diseases, and depending on what is involved, they can be classified into simply seronegative spondyloarthritis, SNSA syndrome, ankylosing spondylitis, which is the spinal type of SNSA syndrome, which can be primary, where sacroiliac joint and ascending to spine, or secondary. This is called as Mary-Strumpel type, and this is called as Best-Roos. So here there is descending SI joint, then descends, causing asymmetrical lower limb large joint involvement. So this is the ankylosing spondylitis, which can be primary or secondary. Now, So this basic pathology would help you diagnose or clinically examine and rationally understand what is the basic diagnosis. After that, you will be asked the management. So you will have to investigate. Investigation has to judge the general condition of patient. Then it has to look for the microorganism which has the peptidoglycans. Usually you don't do it. Then it has to look for the HLA type or predisposition. Then you can measure the immune complex and the inflammatory reaction is measured by C-reactive proteins. Then you have to be careful about how high is the immunoglobulin, is there a danger of amyloidosis or not, that you can judge by serum uric acid. Another investigation which is less sensitive is erythrocyte sedimentation rate. Then you have to actually image the joints, image the affected joints. And basic is X-ray, then CT scan or MRI can also be done. PET scan can tell you the inflamed joints. So for surveying the inflamed joints, you can do a PET scan. But basically, an X-ray is sufficient to tell you a lot. Then you assess the function. Activities of daily living, especially gait. If it is the hand, you look for the prehensile function, which means that reaching the hand where it is needed to reach by the shoulder and the elbow, the pronation, supination. Then the pinch, grasp and hook. In the lower limb, along with the gait, you examine standing on each limbs, one limb, both limbs. You examine the sitting on a chair, cross-legged, squat. You examine climbing up and down stairs. You examine painless walking distance. And basically, if the costovertebral joints are involved, you must do a pulmonary function test. Then how do you treat? The treatment is heat of the affected part, heat and exercise. Then to decrease the inflammation or protect the joints, you can give non-steroidal anti-inflammatory drugs The most effective in this is indomethacin. Then the third level is you give what are called as DMARDs, disease modifying anti-rheumatic drugs. So the DMARDs for the seronegative spondyloarthritis is salazopyrene. For the rheumatoid arthritis, it is gold, chloroquine, levamisole, penicillamine. Thirdly, you may give, and there's one more, which is azathioprine. Then you can give immune suppressors. And these immune suppressors are methotrexate. And you may have to supplement methotrexate with folic acid to prevent its toxicity. So basic thing is that heat and exercise and NSAIDs as needed, whether NSAID or DMARD or immunosuppressors. Now recently the immune response has been greatly researched, and there is a interleukin 6 which affects receptors on the cell which activates STAT inhibitors which cause nuclear proliferation and development of an immune reaction against the concerned tissue. So you can give IL-6 blockers or STAT inhibitors. This is tositonib or STAT inhibitors, and the enzyme here before it is called as Jackson kinase enzyme. So you can give Jackson kinase inhibitors or STAT inhibitors or antibodies against these receptors or interleukin 6. So this is the modern component of trying to control rheumatoid arthritis or immune articular disease. The next is osteoarthritis. Basically knee, old age, usually no swelling, usually both knees, usually pain, progressive varus, genu varus, wasting, and limitation of movement. ROM becomes less. So this is the picture of knee osteoarthritis. What you should know is that the cartilage consists of collagen, and in the collagen there are lacunae, and in this lacunae they are paired cartilage cells. So here is the subchondral bone, and the subchondral bone has a calcification beyond which the blood vessels will not be able to go beyond this. So there will be a hairpin bend, they will come back like this. Now, this consists of, collagen consists of fibers like this, and these rings go on getting flatter and flatter as you reach the tip. And this collagen has got something which is called as hyaluronic acid. Now what happens that this hyaluronic acid binds with it H2O, and this cartilage gets supplied by the synovial fluid, which is here like this, and by diffusion across this zone from these blood vessels. There are blood vessels which turn into small sinuses, blood sinuses. So they receive nutrition by this, and that enlivens the chondroblast. Now this synovial fluid between two cartilages, there's synovial fluid, and in rapid movement, this synovial fluid is so viscous that it remains in between the two cartilage. Therefore, there is no rubbing off of cartilage, and this type of locomotion, the motion is called as hydrodynamic lubrication. It's called as fast movement. Synovium will not be able to escape between the cartilage surfaces, and that type of lubrication is called as hydrodynamic lubrication. If there is slow movement, then this water will be squeezed out and will remain between the cartilage surfaces. So that is called as hydrodynamic. So what happens with age, that this collagen, usually there's collagen type 6. It is gradually replaced by collagen type 4. And because of that, these chondroblasts are not able to synthesize sufficient hyaluronic acid. So the water goes. So what happens? Nutrition suffers, especially in pressure bearing areas. So what happens that hyaluronic acid decreases, and because of the decrease of the hyaluronic acid, water is not retained. The cartilage becomes pale, shrunken, fibrillar, and can be easily rubbed off. So when it is rubbed off, in the synovium it floats as detritus. And if it is rubbed off, it can reveal the subchondral bone. So that subchondral bone, where you see it, is called as hibernation. And under the hibernation, there can be microfractures of trabeculae. These are the trabeculae microfractures, and because of these microfractures, there is subchondral sclerosis on X-ray. And there may also be cysts. In non-pressure bearing areas, blood vessels invade the cartilage and whenever a blood vessel invades the cartilage, there is ossification. And these ossification is called as osteophytes. So this, in short, is the pathogenesis of osteoarthritis. You will basically manage it by preventing. And this prevention is decrease weight, decrease trauma, decrease long time one extreme position, like standing in policeman, extreme position like policeman standing for long time. Prevent abnormal forces. For example, if the joint is not perpendicular to the direction of force, it is like this. Therefore, this force will produce sliding of the upper over the lower. So instead of the force being a compression force, it will become a shearing force. The second thing is that if the area is less, then force upon the area is called as pressure. So, for example, there are achondroplasics. Now, the area is less, therefore and if they have weight, they are bulky, then a lot of force is passing through a small area, leading to a lot of pressure, which will produce the pathogenesis of osteoarthritis. So, then the treatment. Treatment is deal with obesity, decrease the force, that means stick in opposite hand, stick in the opposite hand, then you can inject external pain points. You can give cartilage regenerating drugs. You can exercise muscles which will better protect the joint. You can give platelet rich plasma. You can correct the deformity that can cause osteoarthritis so that the line of weight bearing becomes all right. And if the joint is totally destroyed, then you can do a total knee replacement. So these are the various common causes of joint pain, and this is how you manage them.